All right, welcome back to Rebelcast. This is episode 125. I'm Salim Razaya, your host. The title of this episode is The First 48 Hours of Pulmonary Embolism Management. How good is unfractionated heparin? Now, I think most of us can agree the mainstay of treatment for symptomatic pulmonary embolism is anticoagulation. And it has been my experience, and the authors of this paper believe that patients with higher risk PEs, so these are our submassive and massive PEs, may require more advanced interventions, things like thrombolytic therapy, surgical thrombectomy, or even ECMO. And the thought is because of a shorter half-life and the readily available reversal agent for unfractionated heparin, it's the better agent to go with. And I'm not sure that we have good evidence. I think that is just kind of what we do. Now, before I get too far into the weeds, let me bring in my partner in crime, the buttery smooth Swami. What's up, man?
Good to be here, man. Yeah, not much is going on. This is an interesting article for us to get into, and I'm going to be honest with you. I don't really love unfractionated heparin. I start it when the inpatient side or a consultant requests it to be started, but I'm not following these levels. And I think it's interesting actually to see what happens after starting them and whether I should be pulling for one agent over another more frequently. So this is not directly relevant to what I'm doing, but maybe it should be. And I think there's some good information in this article.
Yeah, and I think most places have pretty standard protocols or order sets for this, right? Like, unfractionated heparin for pulmonary embolism, it's typically 80 units per kilogram for the bolus, and then you start at 18 units per kilogram hour. And then, like you said, it starts getting titrated based on activated partial thromboplastin time, or APTT. And usually the target we're going for in the inpatient side is 1.5 to 2.5 times above the control range. Now, some people might be following 10A levels. That is not what we're doing at my shop, but that's what some people might be doing. So that's pretty standard. But let's get into the paper because, Swami, before you even introduce the paper, I want to put a little transparent caveat out there, and that is that this is not the best trial in the world. But it asks an interesting question. And I think the crux of this podcast is going to be when you and I start talking, debating, discussing what we should be doing in clinical practice. I think that's the more interesting part of this. So with that, let's get into the paper.
All right, so the paper that we've got here is Prucknall et al. Analysis of partial thromboplastin times in patients with pulmonary embolism during the first 48 hours of anticoagulation with unfractionated heparin, academic emergency medicine. This is a couple of years old, but it is starting to rise to the top again in terms of discussion. It was printed in 2020, and their clinical question, and I think the title kind of alludes to it really well, within the first 48 hours of treatment of PE, is unfractionated heparin associated with a therapeutic APTT value?
Right. And so this is just essentially a retrospective analysis of patients who had pulmonary embolism, and the PE response team, or the PERT team, was consulted, right? So there's already a selection bias here, but that's the patient population. It's a single large urban academic teaching hospital, Massachusetts General Hospital, and they recruited patients from October of 2012 to April of 2017. And they essentially looked at two regimens, and I'm not going to get lost in the weeds here. It was bolus plus drip for people who had a low risk of bleeding versus drip only for people who maybe had a higher risk of bleeding, and then titrated to what they had in their protocol for their PTT levels, which I'll have everything in the show notes. And Swami, I think you already said this when you presented the question. Their primary outcome was proportion of patients with a therapeutic PTT level that they checked every 6 hours. And their definition of a therapeutic PTT level was 60 to 80 seconds. So who was included, who was excluded in this study?
So all adult patients, acute pulmonary embolism, they had to receive anticoagulation based on their standard guidelines. And then you mentioned this before, the PERT team was consulted. And the reason that's important, I think this is really important for us to clarify. The reason that's important is because if the PERT team was consulted, they assumed that that meant that there was a consideration for something more invasive in terms of treatment, whether that be thrombectomy, whether it be systemic thrombolytics, or whether it be catheter-directed lytics. And that is really the group where people tend to prefer unfractionated heparin with the idea of, okay, I started the heparin, I want to do this procedure, I can stop the heparin, and the patient is going to be safe to go for that procedure. So that's the group that we're still giving unfractionated heparin to. And that's why it was really just the people where the PERT team was consulted.
And what's interesting is over the 5-year period, there was 505 patients that met their inclusion criteria. And I will put all the specifics in the show notes, but the majority of these patients were submassive PE patients, right? Right heart strain on CT was almost 50%. Elevated troponin level was just over 50%. What's interesting is, and maybe not so much because they're submassive PE, is the interventions received. Systemic thrombolysis, 4%, catheter-based intervention, 5.9%, surgical thrombectomy, 2%, ECMO, 1.4%. Not a lot of procedures done despite being submassive PE patients. And then they also list their 30-day outcome. The mortality rate of this population with submassive PE was only 5.7%. Not that high for a submassive PE. And bleeding rates were only 3%, rethrombosis 3.9%. Now, that's not what the crux of this study was, right? That's not their primary outcome. It was, how good were we when we used standard dosing regimens of unfractionated heparin in this population of patients that were majority submassive PE? How did they do, Swami?
Not that great. I mean, that's kind of the bottom line here. At 6 hours, only about 14% were in the therapeutic range. And I don't know that that is terribly surprising. We kind of know, we are increasing this dose. We're going to have to titrate. It's going to take some time to get to therapeutic levels. But even out to 48 hours, we had less than 30% were in a therapeutic window. And there was no point in time where the majority of patients were in the therapeutic window within 48 hours. So what it really meant was that when we looked at this group of patients that they selected, most of them were subtherapeutic for most of that 48 hours. And I think that that is really interesting for a number of different reasons. I don't think, though, that we would have assumed that based on these protocols. The 18 and 80, the 80 and 18, Salim, has been around since you and I were residents. My guess is it's been around longer than that. But that might be the problem right there. We haven't really done research to say that that is the correct dosing of heparin, of unfractionated heparin, in order to reach therapeutic levels. Nonetheless, these are the numbers that we've got. And then the other interesting thing, I know we're going to get into this more in the discussion, is that even with those subtherapeutic levels, we didn't see massively bad outcomes.
Yeah, I mean, that's what's really interesting. Like, how do you make heads and tails of that? Now, I'm going to list all the strengths and limitations in the show notes. I don't want to get lost in that. Like, the study is what it is, right? It has its strengths, it has its limitations. I think the main results are what I find most interesting. And so that's what I want to kind of get into, which is the discussion. So Swami, why don't you start us off in terms of, like, if you could just summarize what these patients ended up having in terms of these PTT levels.
Yeah, so I mean, the bottom line is that most of these patients were subtherapeutic. And what we didn't mention in those results were those patients that were getting just the infusion. They got no bolus. That group tended to be in the therapeutic range a little bit more frequently, but still under 50%. All of those numbers are going to be in the show notes for people to see. But most of these patients never reached the therapeutic range. And that is, again, sort of both alarming and surprising. And then also when we contrast that with the bad outcomes, I don't know, we don't see much. So maybe the goals that we have set for ourselves are not the right goals. Maybe that's not what we should be striving for when we see a fairly low complication rate.
So what are you doing in your practice for these patients? Are you doing unfractionated heparin, or are you doing low molecular weight heparin?
Yeah, I mean, I would prefer to give low molecular weight heparin to most of these patients just because of the ease of use. And I want to come back to that. I know we're going to talk a little bit more about that. But what often happens with these patients who are in the submassive area is that I speak to the consultant and I ask them, what do you want? You want low molecular weight heparin? Do you want unfractionated heparin? They often will request unfractionated heparin. And so that's what I'll start. And again, I'm not following it. I'm not following those APTTs out afterwards. I'm not adjusting them. So I do leave it a little bit to the consultant, understanding that they're the ones who are going to be managing this patient down the line. Now, if I have a patient where I think that they need either systemic thrombolytics or they need some kind of interventional care, I usually am holding heparin all together until that decision is made. So if I really think that they need one of those interventions immediately, I'm not giving heparin at all because I understand that heparin plus the thrombolytics is going to increase the risk of bad outcomes. So I know that's not really what was dealt with in this paper, but that's kind of what I'm doing.
Yeah, and, one thing to think about with unfractionated heparin is that, the amount of clot burden in and of itself and the duration in which that clot burden has been present can actually lead to heparin resistance. And so that may be one of the reasons why they had so many people in a subtherapeutic range. Now, I'll tell you my opinion is that I'm a low molecular weight heparin guy. And I appreciate the caveat that you stated. If I'm thinking emergent thrombolysis, emergent, they need ECMO, I'm probably holding the anticoagulation till that emergent procedure can be done. And then after the emergent procedure is done, however long after that, I will then start the anticoagulation. And at that point, it doesn't matter because what needed to be done is already done. That's not what we're talking about here. We're talking about patients that, let's call them segmental or submassive PEs. And what is actually the best agent to go with? And my opinion is low molecular weight heparin. And I think it offers many advantages over unfractionated heparin. It's got a longer half-life, increased bioavailability, it's a more predictable dose response, and it's weight-based and administered subcutaneously. And so it doesn't really require dosing adjustments or laboratory monitoring, whereas unfractionated heparin does. Now, we can follow anti-10A levels, and typically the way you do that is you give the Lovenox, wait 4 hours, and then check a 10A level. But we're largely driving kind of blind, right? The other thing that we didn't talk about is unfractionated heparin typically cleared hepatically, low molecular weight heparins typically cleared renally. And so, patients that have renal dysfunction, chronic kidney disease is an interesting population to also think about.
Yeah, I think all of those are interesting. And I think also is the issue, you mentioned it up top, most of us are not following factor 10A levels. And so we don't really know with that low molecular weight heparin if we're in the therapeutic range. I'm sorry, the anti-10A levels. We don't really know if we're in the therapeutic range or not. We kind of assume we are based on the dosing that has been put out there. And so perhaps with the low molecular weight heparin patients, we're also subtherapeutic. But again, it comes back to maybe that doesn't matter. Maybe even in that subtherapeutic range, we're getting what we need. And I think obviously the data here is limited by so many different things. It's retrospective, it's single site, all of those. But maybe we just don't need to be aiming for as high an anticoagulation level as we are. And what this kind of says to me is we really do need more data on what window we should be aiming for. What is the optimal window to both get the benefit of those heparins, whether it be low molecular weight or unfractionated, but also balance out the possible harms. So I think all of these things are important for us to be looking at. We don't really have great data, but I think this study asks a lot of important questions. Now, whether anybody studies this or not, I can't say. These are not expensive drugs. There's not going to be a whole ton of interest in doing big randomized controlled trials, looking prospectively and seeing what the right dose is and what the right dose range is. But it would be nice if we get those so we really can advise care.
Yeah. And look, two things. So number one, in 2017, Cochrane did a review comparing low molecular weight heparin to unfractionated heparin for the initial treatment of VTE. And they included 29 randomized clinical trials with over 10,000 patients. And here's what the authors concluded: that there was moderate quality of evidence that fixed dose low molecular weight heparin reduced the incidence of recurrent thrombotic complications and the occurrence of major hemorrhage during initial treatment, but there was no difference in overall mortality compared to unfractionated heparin. What you do with that information, I don't know. Again, it's like there's morbidity factors that are affected, but it doesn't really seem to impact mortality. And that remains consistent with this study and what the Cochrane review found. And then the second thing I'm going to tell you is that there was a 2019 European Society of Cardiology guidelines that was put out. And I'm going to quote them, but they basically said low molecular weight heparin and fondaparinux are preferred over unfractionated heparin for the initial anticoagulation in PE because they carry a lower risk of inducing major bleeding and heparin-induced thrombocytopenia. Now, that statement went on further and talked about patients with hemodynamic decompensation or hemodynamic compromise, patients with altered renal function. But The crux of it is that we're getting the same message over and over and over again, yet practice seems to be unfractionated heparin in lieu of a procedure that's going to happen.
Yeah, I think these are all important points. And I think if we have a comparison telling us that low molecular weight heparin and unfractionated heparin lead to similar outcomes, except that there is less bleeding, then even without the ability to follow levels, what we're being told is that that's probably the best approach. And we didn't even talk about the fact that using low molecular weight heparin saves money. It's easier to administer. There's no tests to follow. There's a ton of time. I mean, Salim, I haven't been on the medicine floors in like 20 years, but I remember chasing these PTT levels, and we hated it. We hated it so much. I'm sure the nurses hate it. So there is a savings to be had here. And if we're not really changing the outcomes, then that savings makes sense.
Exactly. So, Swami, what did the authors conclude from this paper?
Yeah, the majority of patients with acute pulmonary embolism spend most of their first 48 hours outside of the therapeutic range of anticoagulation when treated with guideline standard dosing of unfractionated heparin. Over half the patients failed to achieve any therapeutic PTT level within 24 hours of unfractionated heparin initiation, and no patient had all therapeutic APTTs. Future research should focus on identifying factors associated with achieving therapeutic anticoagulation with unfractionated heparin.
Which is a lab-oriented outcome, by the way.
Oh, yeah,
It's
of
not
course.
a patient-oriented outcome, right? So our clinical take-home point, in this single-center study of PERT team consulted pulmonary embolism patients, standard dosing of unfractionated heparin left most patients with a subtherapeutic activated PTT level in the first 48 hours of treatment. Now, that's what the authors said. My takeaway from this is either we need to question the dosing regimen that we use of unfractionated heparin, or maybe we should just consider switching to low molecular weight heparin in the initial treatment of PE patients for many reasons that you already stated. Cost savings, less labor intensive, less bleeding, and doesn't really seem to have any difference otherwise in mortality. All right, Rebel Am listeners, let us know your thoughts, comments, and questions. Thank you for tuning in, and until next time.